we are not going to get to class 1 unless we do more. And what that more is going to be, you already know it because I told you earlier, it's going to be adding in a Carriere motion. So we certainly could have used this Carriere motion from the very beginning, and in retrospect, I would have used this Carriere motion from the beginning. Now, here's something that I will tell you again is a mistake, just like you guys, I go through the same crap. And so what I did is she's wearing her heavy force 1 and force 2 elastics. Don't have the patient go to a lighter elastic at this point. The reality is that orthodontics should be called compromise odontics. What compromises are we going to make? Are we going to compromise by not fixing her overjet? And that might be valid. We could have just straightened her front teeth. What's the patient's concerns? What are we trying to accomplish? I want to talk to you about today is we're going to be talking about 2 cases where we're looking to use Carriere motion appliances. So a Carriere motion is essentially a bar that gets glued to the teeth that allows you to hook on heavier elastics to make stronger movements and forces happen. Now, Carriere motions are not magic. They do require the patients to be very compliant still, and there's some downsides. So my goal, like I always tell you guys, is that I want you to see the real world in terms of how we actually apply things. And so I'm going to show you things that don't work out as effectively as we want, as well as the things that go really well. So to start off with, this is our patient. So she comes to our practice and she is 23 years old. When we look at her facial balance, you can see from her Ceph, she's very hypodivergent. So what does that mean? Well, it means that when we actually look at the planes of her face, if we were to take a ruler and draw a line on her mandibular plane angle, occlusal plane angle, palatal, and if we do her Frankfurt horizontal on her ascent angle, what we would see is that all of her plane angles, they all run parallel to each other, meaning there is a small amount of divergence between these lines. She's hypodivergent. Another term for this is brachyfacial. So essentially, she's a strong muscled patient. You can see it in her masseter when we look. She's got a strong masseter. She's got a short lower facial height. She's slightly dished in with her face. Now, when we look at her occlusion, we see that on her right side, she's in a perfect class 1 molar canine. On her left side, she's not. And so in the past, this may have been treated to correct the AP by extracting unilaterally 1 premolar. But her face is so non-extraction. If we were to take out any of these teeth on her maxilla, all it's going to do is retract her maxillary lip, and that's going to give her a more distant facial appearance, because that's just the profile that she has with a more prominent nose, being hypodivergent and having a more prominent chin, is that she has a distant face. So for facial aesthetics, we would never dream of, in my opinion, extracting a premolar so that we would correct the class 2. When we look to the angulation of her posterior teeth, right? Somebody could make the argument and say here, well, I mean, what are we trying to do in terms of any class correction? Because when we look at her teeth, it's not like her teeth are super crooked. Could we not just go ahead and line up her lateral incisor, maybe line up her lowers where there's a bit of crowding and call it a day? But when you look at her premolars, you can really see it in quad 1 and 2 on both sides. Her premolars are angulated towards the lingual. There's a lingual crown torque. And if you look at the gingiva, you can start to see that there's a rolling of the gingiva, and there's actually a small amount of recession that's starting. That's because the teeth, as they angle lingually, it's not as bad on her right side, but you can think of it like a nail. If you're hitting that nail straight up and down with the hammer, it's in the right orientation. But if you hit it at a slight angle, it's flexing at the neck of the nail and it bends the nail. And so that's the reason that, in my opinion here, we're not just focusing on the social 6. We're focusing on all of these teeth because all of the teeth would benefit from, for sure, arch development and expansion. But if we could go ahead and move back her teeth in quad one, or sorry, quad two on her left to put her more into a class one occlusion, how will that play out with her facial balance? So let's go ahead and take a look. Well, when we look at her smile arc, she's not giving us the best smile in the world, but we can definitely get some information here. Look at how her upper right canine sits quite a bit lower. It's inferior to her upper left canine. So let me draw on this. Right? She has a cant. So there's her gum line here, but on this side, her canine's probably somewhere around right here. Her lateral versus the other lateral, and then looking at the centrals. So she's canted. Now, part of it's because there's some wear that's occurred asymmetrically on her canines. But the other thing is that when we look at her midline is actually deviated towards her right. Same thing, let's draw on this. So the middle of her face, her nose, and then her teeth are further to her right. So if we were to have some class 2 correction towards her left side, that would actually be beneficial. If we could also extrude her canines and that lateral, that would also be beneficial. Now, you could also consider saying, well, Stephen, could you not place a TAD and try to intrude these teeth? Because I have talked about that before, how we can utilize TADs to make specific movements happen, especially if they're hard movements. But yes, you could theoretically use a TAD. The question would be is, would I rather have her show more gingiva or would I rather have her show more teeth? In her case, when she smiles, first of all, again, she's smiling bigger than she normally might. But I don't want to intrude teeth and get rid of all gingival display because the more gingiva that you lose, well, the older you look. Because as we age, our lip line drops by 0.1 millimeter per year. So every 10 years, our lip line is going to drop a millimeter. So if we prematurely age them by intruding these teeth, in the future, it's not going to look good. She's only in her 20s. So I would much rather, in her case, deal with the correction of this cant through extrusion rather than intrusion. So, other than that, do we have anything significant going on? Her pen's pretty unremarkable, some fillings. She does have some resorption already occurring on some of the roots, so we might just want to keep in mind that she has shorter roots, but nothing that is too extensively abnormal. And again, if you look in the mouth, you can really see the difference in terms of the height of the canines relative to one another and that canting that's going on. So what, again, I'm going to show you as we jump into this case here, things that I do that are not done the best, right? When we look at her case here, you can see how class 2 she is. She's a full molar class 2. On her right, she's biting an ideal occlusion. And again, her canine and lateral sit much higher. Now, often what I do when I'm going through all of these cases for you here is I'm going to break out every single attachment decision. But I'm not going to actually do that tonight. Instead, I'm going to be doing a bit more surface overview. So I'll go ahead and explain specific aspects, but I'm not going to go through the whole checklist of absolutely everything that we did on this case in terms of attachment decisions. Because in reality, there's some stuff here that I didn't do that well. So what are we doing in her case? Well, to start off with, we need to correct the torque on these anteriors, right? They're quite retroclined. And the thought is that when you have a patient who has retroclined anteriors and has constricted posteriors, which we know she has, right? Look at her premolars. We see how they're lingually inclined with lingual crown torque. What's happening is the mandible is stuck here. This lid and the box are kind of fitting together so tight. And so the idea that I had was if we fix the torque by proclining these anteriors and we widen the arch and create arch development, then what we could do is maybe we will see some spontaneous repositioning of the mandible. So you can see the expansion in the posterior. There's also derotation of those molars. There's torque correction, and there's some pretty extensive torque correction because where these teeth first start off, they're extremely retroclined. Well, the amount of torque correction, we could actually look at it here if we go to our table. That's just our movement assessment. Where's our tooth movement table? Would tell us that the anterior teeth, when we look at the root positions here, we have 27 degrees of torque. Another thing that, again, I show this in the courses, but I love being able to show you right now because you can see things much better here. If you want to just evaluate and isolate one movement, you can click on this customize button. So you can actually see in this table only things that are actually relevant to what you want to see. So for example, I don't really care about intrusion or extrusion, so let's get rid of this. We're not doing any significant translation buccally or mesial distally, so that's fine. So let's say I care about rotations that are going to be more than 5 degrees. I care about root tip that's maybe going to be more than 5 degrees, and maybe I care about seeing where we're doing torque of more than 10 degrees. This now gives us a perspective as to what the specific movements are that are more significant. Now, I don't actually love the way it's showing right now. I think I can zoom in here. There we go. If I just use my mouse, my scroll wheel, and hit Control, I can zoom in or out. And if I zoom out, then it gives me all the teeth on the top and the bottom. You see how it's showing like since we're using international tooth numbering with the Canadian system here, this is 1/8 through 2/8 and then 4/8 through 3/8. But if I zoom in slightly, now all of a sudden it just shows me the maxillary teeth. Just reduces what I'm looking at. So what it really shows me here is that, sure, we've got some root movements that are occurring, and let's even just hide the angulation for right now. And let's even hide the rotation. But if we look at the amount of torque that we're trying to correct, we see that there's torque happening in the posterior, and we see there's torque happening in the anterior just due to the extensive correction that we're making, which is totally logical. It should look that way. It should be overtreated. So that's how you use the tooth movement table to isolate a specific movement if you just wanted to see the torque. Again, let's say we just wanted to look now at rotation. So we hide the torque, we look at the rotation, and I got rid of what I had done before. Let's say I just want to see rotation over 5 degrees. Then it grays out everything else. So I can see, all right, my upper first molar has some derotation. This upper second premolar has a little bit of rotation, but is not very relevant. This canine has 17 degrees of rotation. This is quite a bit of rotation. Okay, so yeah, there's a distal out, the lateral, 20 degrees of rotation, mesial in. If the mesial is coming in, the central, it's going to have a distal out. We're on still highlighted root, by the way, so you should actually click on crown there. So the 1-1 has a mesial in, distal out. The 2-1, same thing. There's a decent amount of rotation on that guy. 2-2, 2-3. So that gives us an understanding of just how significant the movements are that are actually occurring. Okay, so again, maybe what I will do, how do I say I won't do it and then I end up doing it here, is I will pull up my text expander just for a second, just to show those who don't see how I normally go through ClinCheck. But I'm not going to go through every component of it. So again, in my text expanders, I essentially have a checklist for me to review. I type in CC-adult, and this whole checklist pops into place. There it is. And now I can go through every single line and evaluate the decisions of if things were done properly or not. So again, it starts off with the technicians do everything right? Do we have passive aligners? Did we pay attention to the smile arc, to the cant? We already talked about that. Is IPR needed for different things? Are there pontics or eruption compensations, et cetera, et cetera? But the main one that I want to get to right now isn't to deal with attachments or anything else. It's to deal with this section that you see right here. Determine if there is requirements for the anterior posterior correction. And if we are correcting the anterior posterior, did we place the right attachments And do we place the right cutouts? And then if there is a bite jump, this is the crucial one again. If there is a bite jump, is it appropriate for this patient? So I want you to think about this, right? You have a patient coming into your practice. They're 40-year-old male, and this is what they look like. If it's showing this patient on your ClinCheck, starting off in this position, and then all of a sudden they're jumping forward 8 millimeters, they start in a major class 2, and then they finish in a perfect class 1. Is that going to happen? Well, let me just explain first what this bite jump is before you give that answer. So this section right here, this bite tab, if you click on it, it will allow you to show a change that happens. I always recommend you click to do it at the end of treatment. What it does is it simulates here with this little checkerboard last liner right here. It simulates what happens not from aligners, but from elastics and changes either to growth or to the skeletal structure in some way, shape, or form. So essentially what this is showing us right now then is it's saying, hey, if you have this ClinCheck and you procline these teeth and you fix the torque and you widen the arch and you do all these things, this is where you will be at. And then if this patient is growing and you modify their growth through using elastics to slow down their maxilla and speed up their mandible, or you're using the wings on the trays, or you're using a Herbst or using some other class 2 corrector, how much will the jaw jump forward through that growth modification? Of course, this is not actually happening in the real world. It's not that the jaw all of a sudden magically jumps one day. It's from growth modification that's occurring consistently. It's something that's happening over the entire process of the Invisalign through the use of elastics or the whatever appliance it's going to be that's changing and modifying their growth. But there is only one circumstance in a non-growing patient. Let me remind you here, this patient is 23, where we will see a bite change happen in the anterior posterior. Chances are really just one because there is some other things that we can do, but there's one primary way. I always love asking this at the courses, live and in person, to see who gets this right or not. But the one way that we see the changes in the anterior posterior growth being modified is through a patient who has a condyle that's being forced posteriorly. And as we widen their arch, we intrude their deep bite, and we fix the torque, their mandible will spontaneously reposition into the spot where it wants to be, based on the anatomy of the condyle and the musculature. So we will see spontaneous repositioning in patients who have TMD issues. They may not be suffering symptomatically from it, but often what will happen is as they open and close, they're gonna open and they're gonna have a click. What that click is as they open, the click is actually their disc being recaptured. So as they're opening and they're deviating often. And then click, their jaw pops back into place because they've recaptured that disc, right? They have disc displacement with reduction. It's still going back to where it was. It's jumping back into position. And so in a case like this patient does have a click on her left side. And so the thought process is, well, if we can recapture the proper position of her jaw, can we accomplish an anterior posterior improvement? Well, it depends. First, let's go ahead and take a look. There's one tool that is so frustrating that it's not here. I'm always so annoyed that this tool doesn't exist just yet. I mean, I sound so like bitter and jaded with this. I'm not that frustrated. It's pretty easy to figure it out, but like it would just be nice if it was included because there's this awesome overjet tool right here. So I love that we can see what the overjet is at the initial and at the final to get an understanding of where the positioning is. But what I really wish was shown is the overjet changes due to a lot of different things, right? The proclination, the expansion, any derotation of teeth, that'll change the overjet, but also it'll actually change the overjet with this simulated bite jump. But what I really want to know is that if we were getting them to correct us to class 1 just using this bite jump, 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 jump. How much is this bite jump? That's really all I want to know. That's what's showing in this section here when I'm talking about this rule of 2, 4, and 6 millimeters. I just want to know how much is the jaw going from here to end up in the ideal spot. Because if it's an adult patient who has TMD, well, the maximum amount that you'll likely be able to see is 2 millimeters of anterior posterior repositioning. If this patient is growing, then we could probably go ahead and see up to 4 millimeters of a bite jump. And 6 millimeters is where we need to consider things like sequential distalization for growing patients as well. If it's 4 millimeters in a non-growing patient, we need to consider sequential distalization or a Carriere if we want to correct this issue. So, how much bite jump does this patient have? Well, let's look. So if we line up this grid line, get you a better view here. Here, I'll give you, you don't want to see me. You just want to see the grid line. Okay, here's the grid line. We've lined it up, and if we toggle one further spot here, we can count then from this more, I also wish they made these grid lines a bit bolder, but if it's from right here, so it was 1, 2, 3, almost 4 millimeters, almost. So what does this tell us? Well, in reality, you will never have an adult patient who will spontaneously correct with arch development, deep bite correction, and torque correction more than 2 millimeters. Now, never say never. There might be somebody who goes 2.5 millimeters, but in reality, are they going to go 4 millimeters? Is it possible that we could force your condyle back 0.5 centimeter and then have it reposition? In my opinion, it's unrealistic. So instead, we need to be looking at something like sequential distalization or a Carriere motion. But I told you here, I'm going to show you things of where I don't do things properly, where I do a poor job. Now, I looked at this case and I said, well, maybe she'll get more. Maybe she'll get more than her 2 millimeters of spontaneous repositioning. And remember, you might get 0. This is not a guarantee that you will get 2 millimeters. It is a maximum of 2 millimeters. You might get 0. It might not be that they're restricted or posteriorly positioned. The only way that you can actually know if their disc, if they're sitting too far posterior, is actually an MRI. A CT will not actually show you because I was talking actually to my friend Reed Friesen. He's in oral medicine and pathology doing a lot of TMD work at the University of Alberta, probably the smartest person I know. He was talking to me about different studies showing that the anatomy of the disc is so unique and different that there's no way to definitively tell on a CBCT without having a previous reference CBCT from before TMD started to know if the thickness of that disc is just thinner or if the anatomy is different. So you can't just look at your CBCT and say, well, here's the condyle, it's not perfectly in the middle. Technically, you need an MRI. So if you don't have that MRI and you don't know if the disc is actually displaced or not, everything we're doing right now is kind of just like a hack it out of the woods. It's like we're in golf. We're starting off in the woods. We're just hacking it back onto the course. And then from there, we can go ahead and make a determination of, okay, well, now, did we get some spontaneous repositioning? Yes, we did. Okay, well, where are we currently at? But if you see 4 millimeters, you know we're probably not getting this all through spontaneous repositioning. So what I do as an error with this ClinCheck then is I'm showing this is the accepted ClinCheck right here, number 2. I show the correction of the torque. I fix the deep bite slightly. I widen the arch, and then here we are, boom. This magical, massive jump forward, assuming this patient is growing, pretty much. Like if she was growing, this would be totally fine. Because as a growing patient, you will see 4 millimeters of AP correction change just through growth modification, but she's not growing, so this is a fantasy. This is not going to happen. So let's take a look and see where this patient's at. Oh, and let me just point out, I use lingual attachments here. We use lingual attachments on most of our cases, so it's super aesthetic, so that nobody sees what's going on with those lingual attachments, but it gives us good control over the teeth. So she's actually eating with her aligners in, changing every 3 days. So she comes back. And if we compare where we first started to where we're currently at, have we had any significant AP changes? Nope, we have not. We have some arch development. And actually, I guess here, this is technically where she's at the end of her first batch. So let me go the right one. So from here to here, you can see her hygiene's poor because she has inflammation between her teeth and the papilla area. I guess actually, no, I take it back. She may have had actually 2 millimeters of AP correction here. Check this out, right? When we look at her initial, compare the positioning of that upper right canine to the lower, so it's definitely in front of that lower. The angulation of the picture is pretty similar, but now it's actually more even. So she probably had about 1 millimeter of spontaneous correction on its own. What do we plan for the second ClinCheck? Well, let's go ahead and take a look at where we're at. So the torque still needs improvement, right? You can see that even with all of that extra torque that we've planned, we still didn't accomplish it. So we need more torque correction. But what do I end up doing for our plan? I actually leave this with less torque correction than what we actually had in our initial plan. In the first one, I've over-treated it slightly. I could have over-treated even more. In our second plan, I don't treat it enough, and I still rely here on our class 2 elastics to try to make that change. And so the reality of this is that if we don't have enough torque correction, well, that doesn't give us enough overjet, first of all. But then the second component to things here is that if we have gotten our 1 millimeter of AP changes, are we likely to get that much more? Again, maybe 1 millimeter, but this ClinCheck is not going to result in her biting in class 1. It's just not going to happen. So this is what we planned, pretty much the same ClinCheck, other than worse torque than last time. And she goes through the rest of that ClinCheck, and where do we get to? Well, let's go ahead and click to her next ClinCheck. So on this right side, everything is ideal because she started in class 1. But on our left side, what you're going to notice here on this ClinCheck and on her plans is that I recognize at this point that we are not going to get to class 1 unless we do more. And what that more is going to be, you already know it because I told you earlier, it's going to be adding in a Carriere motion. So we certainly could have used this Carriere motion from the very beginning, and in retrospect, I would have used this Carriere motion from the beginning because we spent now the last 7 months. Yes, we widen the arch. We fix some of the torque. We intrude a little bit of the deep bite. We did arch development, but in reality, we were always going to need some anterior posterior correction as well as the transverse. And so, again, looking at our current position here, what we're going to be doing is gluing on a bar. Now, this is the end of the next series, so I don't want to give too much away, but we're gluing on this Carriere motion. And in adults, we always use a clear Carriere motion. Now, the Carriere motion can hook on either from the first molar to the first premolar or from the first molar to the canine. The difference between the two is it's less aesthetic when it runs to the canine because as these teeth distalize and back up, it's going to create a space between the teeth like you see here. And you can see this from the occlusal view. We're kind of jumping ahead, so you're getting the spoiler. But this is where she's at after that second series of aligners. Well, after our Carriere motion, look at how much space has been created through the distalization of the premolar and molars. Now, the way that we're able to accomplish this is that we hook on an elastic to the Carriere that's very heavy. So where do we hook it on? And how do we set up this ClinCheck? So if you are in a position where you're wanting to have further class 2 correction, what do you do? How do we accomplish this? Well, the Carriere motion, first of all, is sold by Henry Schein Orthodontics or through their subsidiary, which is Serum Ortho in Canada. Just Google Carriere motion and you can find them. Now, the Carriere Motion glues on just with orthodontic cement. So do not use crown and bridge cement. Also, do not use composite. Use orthodontic cement. Like Transbond, that's an ortho cement that you would use. There's a number of different ortho cements, but Transbond is one of them. And so the button that goes on the lower has a specific cutout position in the tray. So we're going to be placing this on the mesial aspect of our lower second molar. We place it intentionally on the mesial aspect because placing it on the distal aspect often results in that tooth rotating quite a bit. Right? I want you to think about how elastics would hook on. So if you were to hook on the elastic rubber band on the distal aspect, let's just use red. So we're going from right here. The way that elastics work is think of them like you're almost grabbing the tooth with the elastic, and then imagine that you're grabbing with your fingers now. Here's a finger and here's a thumb. So you're grabbing those elastics and you're pulling. Well, the further back that you are, the more rotation of this tooth will occur. The further forward you are, the less rotation will occur. So theoretically, if you were able to put a button like right here, this tooth is not as likely to spin. Whereas if you put a button way back here, the tooth is much more likely to spin and rotate on you. The challenge is this though. The real world implications can be hard that if you put your button like right as close to the interproximal as possible, like right here, whether it's a button or a Kaplan hook, which is just essentially a little hook that's on there, it might be so close to the interproximal where the tooth is starting to round that what ends up happening is that your elastic will keep slipping off the tooth. So if you put like a button right here that has a little neck on it, the further in versus let's say you put a button like right here that has a little neck on it, the further interproximal you go, the more likely it is that the elastic will slip off because it can hook on more. It's essentially just that the nub that the elastic actually hooks onto is at a more mesial angle. It's going this direction. Whereas when it's in the middle of the tooth, the nub is coming straight out. And when you're on the back of the tooth, the little nub, whether it's again a Kaplan hook or whether it's an actual button, is more distal, so it's going to grip on better and it won't come off. So from a practical perspective, it's easiest to actually hook your elastic on to something on the distal of the tooth. But from a rotational perspective, if it is the very last tooth in the mouth, you don't want your button cutout to go on the distal aspect. You actually want it to go more on the mesial. So I would actually be trying to place my button in this scenario, not right on the mesial. You'll see in the picture of where we do actually place it, but I would try and place it like right here so that it's further forward than if we'd placed it in the back to try to keep the unwanted spinning to occur, but not too far forward that the button will keep slipping off our elastic. Right? And this is the Kaplan hook. Essentially, it is a pad that gets glued to the tooth, and then it's got a little loop on it. So the elastic can hook on better with this Kaplan hook compared to with just a standard button. Okay, so you'll also notice on the ClinCheck, pretty glaringly obvious that we're missing all of our teeth because we can't have the plastic sitting right up top if the Carriere motion is going to be going on, right? So what we've asked the technicians to do then is we've asked them to please virtually remove all of the teeth. So I've asked them specifically here, virtually remove the upper first premolar to second molar and treat only from the, well, this should be the virtually remove the upper 4 through 7 and treat only from the 2, 3 to the 4, 3. I should have really said, I don't know why 2, 3, 4, 3. It should have just said treat from the 2, 3 to the 1, 7. I also asked them to remove slightly the distal aspect of this canine, because if they make that canine pristine and perfect, well, then the plastic will cover the whole distal aspect. And in reality, right now, there's no space for the tray to actually get fully down the distal side of this tooth. It's going to hit against that premolar. Once we start cracking space open around that canine, well, yeah, now we've got lots of room for this, and it's no big deal. But right now, if they just virtually remove those teeth and then they run the aligner way up here, it could be that the tray won't actually fit. It's going to kind of wedge itself in between the canine and the premolar. So that's why I've asked them to remove a little bit of that distal as well. So I'm telling them here, the canine's going to be wearing Carriere Motion and show an elastic jump. I've referenced a previous case that I've done in case they want to review that. And so this is essentially the design. It's showing a bite jump, but it's actually not going to be from the mandible coming further forward. We've already clarified that. The mandible isn't going to keep growing magically. It's actually going to be from the maxillary teeth distalizing. So whether you show a bite jump or not here, it doesn't matter because it's not going to happen. So the results you've seen already. We run the Carriere motion and we utilize what's called a force one elastic. So let's have a quick break to talk about elastics. Some of you may have seen me lecture on this before, but let's talk elastics. So elastics are not that hard. There's essentially different sizes to elastics in terms of the diameter, and then there's different thicknesses. So in terms of the size of the elastic, if we were to simply take scissors and cut that elastic and lay it along a ruler, so what is the diameter of the elastic? We would measure to see, okay, the smallest is a 1/8 inch. The largest is a 5/16 inch. What does that all mean? Oftentimes people get really confused by that, so I want to help clarify that point. So if you were looking at a standard meat and potato elastic that you'd use almost all the time from like the upper canine to the lower first molar, you would be looking at using a 1/4 inch elastic. That's the size usually from the canine to the first molar. If you weren't able to do it from the canine to the first molar, well, maybe you'd go slightly smaller and you might go from the first premolar to the first molar. Well, in that case, you'd use a 3/16 ounce elastic, or sorry, 3/16 diameter elastic. If they went instead, and I'll just show this graph because this shows it better. So say you can't go from the canine to the first molar. So you're going to go from the premolar, then that's going to be a 3/16. And then if you want to get bigger, you'd go from, let's say you're missing the first molar, you'd go from the canine to the second molar, you'd go maybe a 5/16. Right? And then all you're doing is making it 1/16 of an inch larger or smaller. So 1/4 is actually 4/16. So that's why it goes up by 1/16 of an inch or down by 1/16 of an inch. We almost never use the 1/8. At least I don't. You can use them for other things, like if you're extruding a canine tooth, use a 3/16. If you're using box crossbite elastics, use 1/4. The next thing is the weight. How heavy is the elastic? So your standard meat and potato, again, is your 4-ounce elastic, which is going to be a medium weight. If you're wanting to go heavy, you'd be going with a 6-ounce elastic. And if you want to go crazy heavy, you're going to be using an 8-ounce elastic. So these are the standard sizes, but there's all these in betweens. There's so many sizes that are between 6, there's 6.5, there's 7, there's 7.5, there's 8, there's 4.5, there's 3.5, there's 3. So the reality is you don't need to stock all of these. We would normally keep, I mean, we use 2-ounce elastics usually for kids that are really small. We don't use heavy elastics on these 8-year-olds. We'd be using 4-ounce elastics as a pretty baseline. We'd use 6-ounce elastics on a dude that's going to be a guy that's going to be really hypodivergent, strong muscled. And the 8-ounce and the 6 ounces are what the Carriere Motion appliance uses. They're the heaviest elastics. So Carriere actually has their own nomenclature for it. They call them Force 1 and Force 2. So a Force 1 elastic is a 1/4 inch in size, 6 ounces in weight. So it's quite heavy. And then if you go to what's called a Force 2 elastic, That is an 8-ounce elastic. So like the heaviest intral elastic you'll ever use. And the size of it is actually a 3/16, so it gets smaller as well. And so that's how the elastics actually hook on. So because we're going from essentially the lower second molar to the upper first premolar, we're kind of going the equivalent of our normal distance, which is 4 teeth, right? 1, 2, 3, 4, including the teeth it's hooking onto. That normally I'd be using a quarter inch, 4 ounce if I was just doing something on a kid. But because we're using the Carriere Motion, we're using a 6 ounce, 1/4 inch. As we move up into our next elastic, though, we're going to be using an 8-ounce elastic that is only 3/16 in size, so it's small. And that puts a lot of weight on these teeth. And that's how the Carriere Motion works, is through using heavy elastics to bulk distalize a whole bunch of teeth on the top using the bottom arch as their anchorage. What does this look like, right? So for the first month, you will normally be using the Force 1 elastic. So you should be seeing a little space opening up between this canine and first premolar within 1 month. It won't be as big as what you're seeing here, but there should be a little bit of space. So if you take floss and you floss between their teeth, they should not have a snap. If you're getting a snap, it means that they're not wearing their elastics enough. These patients have to be changing their elastics 5 to 7 times a day. So when they first wake up in the morning, change their elastics. There should be elastics beside their bed. At breakfast, lunch, after school, or like an afternoon coffee, dinner, before they go to bed. That should be 6 times alone right there. And if it ever snaps or breaks, go ahead, change your elastics. Never put the same elastics back in your mouth. They should always be fresh. So the space starts to open. These teeth are starting to distalize. You can see her getting more class 1. Now, there might be a small amount of mandibular repositioning as well. As this torque continually fixes, we still might have that other millimeter of anterior posterior correction from the jaw positioning. Because the other thing that this is doing is sometimes, I mean, I'm getting a little advanced here right now, but sometimes what happens is you might have a patient, right? They've got their condylar issues and you want to get them further forward and you widen the arch, you fix the torque, you fix the deep bite, but their mandible doesn't come forward. The reason why is their muscle splinted. And using just small, light elastics isn't enough to get them out of this muscle splinting. Now, you could have them wear a splint for a month, 2 months, 3 months, 6 months, whatever. They'll potentially reposition from that. But sometimes, even with a splint, they don't actually reposition because we need to overcome the strength of the muscles to pull forward their mandible. And so that's where the use of heavy elastics can be beneficial for also getting mandibular repositioning to get the condyle in a better spot. So I would say realistically here, we probably have a combination of both of these two things happening. We clearly have distalization, but I think if you look at that canine, it's also gotten better. I think we probably got about another millimeter. But the thing you need to be aware of is this, is that there will be circumstances where there might be circumstances where now you can actually muscle splint the patient forward because the elastics have been so heavy, right? We see this all the time with growing patients. A kid start off early class 2, they're wearing their class 2 elastics, all of a sudden they show back up looking like this. And everybody freaks out, and they shouldn't, because it's not a big deal. They're muscle splinted. You try to get them to stick their jaw further forward, they can't do it. They're as far forward as they can go. They're just muscle splinted because of the elastics. So you need to be cognizant that sometimes, if all of a sudden somebody's jaw repositions spontaneously, like 4 millimeters. Now they're biting her like edge to edge. And you're like, oh man, I need to do a whole bunch of IPR on the lower. And I need to now use some class 3 elastics. Then you do that, and then they're back and they go to big class 2 again. You're like, oh, I'm an idiot. They're muscle splinted. So you sometimes need to actually over treat this patient, even if they're biting kind of edge to edge. Don't freak out. They started off more class 2 when it's more of a mandibular repositioning and it's more than your 2 millimeters. It's not real. It's not real. So we probably have a little bit of that too. Okay. So what do we do after this series? Well, we're getting closer to class 1. but we're not quite there yet. I think this photo is always a bit deceiving because it's coming from an angle. I don't know if this is the right angle for you guys, but it's coming at a bit of an angle. So it's not coming right from the side. The more from the side it is, the more true the photo is, but it's getting a lot better. So we're getting closer. So let's look at our next ClinCheck. What are we going to do? Well, I mean, this side here is pretty much ideal. You can see it here. We still need more class 2 correction because of our unideal photo. And so all we're doing is we're not worrying about these teeth backing up because we're going to back them up later. We're just going to back up these teeth that are not actually physically visible in our ClinCheck. Those ones are going to get backed up more. And sorry, I kind of glanced over this before that we're asking them. Well, I kind of mentioned it there, so you guys got the point, right? Like virtually removing them just means that it's an extraction. We're virtually extracting those teeth for the carrier to go in place. So I'm just asking for the exact same virtual extraction. See what my instructions actually say. Oh, that'll be in the next one that we virtually raise the gingiva. But sometimes these demo cases, it really screws up and puts the instructions in the wrong spot. But actually, wait a minute, did it? Let's go back. Let's look. So in treatment plan number 8, they didn't. They did not screw up. I'm just screwing up right now. So here's the thing that I want you to know is that you don't have to, in your brain, figure all this shit out. You can look at this and make a decision based off your ClinCheck. Because what I actually asked the text to do here on treatment plan number 8 was, I said, do not add or remove attachments. You'll notice that I didn't change any attachments the entire treatment. I asked them to not intrude my upper incisors, but virtually cover the gingiva to cover the impliance, and then give me 40 aligners. Notice here how they only raise the gingiva on the 2 teeth that it's glued to. So realistically, if they actually had given me this appliance, this tray would have potentially hit the Carriere bar as it goes up. It might sneak in behind it, but it might not. So you need to be careful here with how you describe things to them, where I just said virtually raise the gingiva to cover the appliance. I really should say virtually raise the gingiva to cover the upper left first premolar, second premolar, and first molar. That's a better way of describing it because we actually need the gums to cover this tooth, to raise up on this tooth too. Why I'm asking for this, and you'll see it later, is that when we ask them to virtually raise the gingiva, the trim line for the aligners is where the gingiva is. So if we virtually raise the gums here, well, that means that anywhere that you see pink gums won't have plastic. What I wanted to see to start with here is, have we corrected enough of this that we're in class 1 that we can start backing up the anterior teeth and use a full aligner again? But if you look, we're still a little class 2. So no, we're not. We're not there yet. We need more distalization. So what I'm going to do then on my next round is I'm going to say to them, I actually don't know if it comes on 9, 10, or 11, but I'm going to say to the technician, okay, here, check this out. This will first just show this concept. On the next one, I just said virtually raise the gingiva to cover that premolar tooth. But then I realized, I'm not quite class 1 enough. Let's get a little bit more class 1. And so what I'm going to do with treatment plan number 11 then is I tell them, you know what? Screw it. Virtually remove the 2/4 through the 2/7. We need to let distalize more with the Carriere first. We're not there. We're not there. We thought we could get there with one batch of Carriere. We didn't. So what are we going to do? Really nothing really. Like a little bit of movement here and there. Like, is that tooth really going to extrude that much? Maybe some of it. But the reality is here is we're mostly just waiting for the Carriere to do its thing. Our lower first molar, you can see that it's doing some weird things sometimes with the elastics. It is actually still rotating a bit, and also a little bit of space got created. Maybe through a small amount of intrusion of this mesial. But if we look at it clinically, it's actually nothing too crazy here. I'm not that worried. Okay, so what do we actually accomplish at the end of our next series? So here's the end of our next series. So we continually work on that correction, backing things up. One thing you'll notice is that the heavy force of the elastics will actually cause us to lose arch width. So if we look to where our premolar is here, you will notice we've actually got pretty good arch development. Aligners are great at expansion. So we created a really nice arch width before, but now our premolar here is actually being dragged slightly in. Because anytime you run elastics from the buccal of the upper teeth to the buccal of the lower teeth, it will always cause some constriction. So what I would potentially do nowadays, without trying to get too complicated for you guys, is I would actually pop on some crossbite elastics. So I'd usually actually go ahead and place a button right here and a button right here. And I would run elastic from those teeth to the buccal of a lower premolar. I would do it to the lower premolar or first molar or something, and that would just help prevent the constriction as well, but I didn't. So we get a little bit further with our class 2 correction. Go back to our ClinCheck for our next series. Now I actually asked them to let things ride on here on 14 one more time. So we went one more time. But the reality is when we actually look to see where she's at, so I compare where she was after our first to our second to our third, the space is getting smaller. Why is the space getting smaller? I want you to think about that. Why is the space getting smaller? Because she's not wearing her elastic enough. That even though we're giving more time and we should be continuing to create a bigger space, if the space is getting smaller and there's no derotation to occur. If we were derotating a bunch of teeth, then it would derotate into that space. But because she's dropping in her compliance right now, that space, this photo's at a different angle, but that space is starting to close. So we need to really tell her to get her butt in gear on this third set and wear them better. So she went from here to there, getting smaller, to us saying, hey, get it together. You've got to be wearing these elastics 5 to 7 times a day. If you don't, you will not be successful. It's just the reality of the situation. And that's, again, one of the biggest keys to success. That's one of the best keys to success that we can have, is that if we explain to our patients how important this is, they can do hard things. But if we don't, then they won't. So here's where we're at our next series. She's in class 1 now, right? So she wasn't before, right? If we go back, she was here, then she was close, then she actually maybe got a little bit, oh yeah, check this out too. She actually got less class 1 from here to there. She's not touching that premolar anymore on the lower. She was touching it. And then here's where she's at. And then we kind of say like, hey, we're wasting our time right now. You're wasting your time. You need to be better. She wears it really well and she gets the class 1. And we say, you know what? Good enough. This is where we're at. So on the ClinCheck, what are we asking for now? Well, now we do this trick where we ask them to virtually raise the gingiva. Once upon a time, what we used to do was this. We used to ask the technicians, hey, technicians, this is where we're at. What I want you to do is please remove the Carriere motion virtually. Or we would physically take it off for a month. And then she'd come back a month later, and then we'd put a button back on the tooth to help pull back the canine or pull back the premolars to keep them back. And any progress that we had from that space, we might have lost a chunk of it because she's not wearing elastics while we're waiting for her new trays. So this is the method for how you can continue with the process of the Carriere. Because in the meantime, right now, while we're waiting for these trays to get made, she still has a tray going from her canine. Like she still has these trays from her canine forward to the other side of the arch. Those are still running. So on this side here now, we have the virtually raised gingiva. And so now we asked them just virtually raise the gingiva. Because once upon a time, I was stupid. What I was doing is I was taking off the Carriere and then we're literally gluing a button to the tooth, right? Why don't we just go ahead and keep using the Carriere to keep these teeth back while we now distalize her anterior teeth? So we have a little bit of intrusion occurring on that first premolar. Doesn't really need to be intruding, but, and then we've got distalization occurring, block en masse distalization while we continue to have her wear her Carriere elastics. Now, here's something that I will tell you again is a mistake, because my goal is not to try and stand up in front of you and say, I'm amazing, I never make mistakes, I do everything perfectly. That would be a total lie. I'm just like you guys. I go through the same crap. And so what I did is she's wearing her heavy force 1 and force 2 elastics. Don't have the patient go to a lighter elastic at this point. I've made this mistake too many times. Have her stay in a force 2 elastic while you distalize these teeth. You still have the Carriere bar. And I wish I had on her case, but I don't have a picture of the elastics or the Carriere with the, let me see if I can find it actually, of the liner with the Carriere. I'm going to see if I can pull it up on my dental monitoring here on another screen while I finish showing you this. But so continue with the force 1 or force 2 elastics, because if you drop to a lighter elastic, the space here, this 2.2 millimeters, it shows it perfectly closing just by backing those teeth up. But the reality is that this space won't close just from the anteriors backing up. It will always close in part from the posterior teeth moving mesially as well. So this is what it actually looks like with them virtually raising the gingiva. It's a little bit close right here. It seems like the tray's still fitting fine with the bar, but she's hooking on her elastic from her lower Kaplan hook to her upper premolar. The idea is that the heavy elastic is preventing these posterior teeth from slipping forward, but make sure you keep using a heavy elastic. Don't go to a lighter elastic while you close that space. So I made that error. I didn't have her continue wearing her elastics to the same weight. And so what ends up happening here, the photo is not the best angle, but there's a few things that are going on. One is you're going to notice that she's actually not biting right now on her premolar. So she was, now she's not. I'd put a little bit of intrusion into that tooth. We also need to settle the bite in her molar and second premolar region. The space is closed. Everything's still straight on her lower, like that's all still fine. Her midline's pretty much on, but we need to settle the bite. And what you'll also see when we actually look at her ClinCheck for this last series now, she's slightly class 2. Her maxillary teeth shifted forward because I didn't use the heavy elastic. So at this point, this is how I finish my cases, is I use our active retainers. It's just aligners, 15 of them, no attachments, no buttons. I mean, in reality, I wish I'd thrown an elastic back on and made her wear that, but she's not wearing it all the time. She's only wearing it 16 to 20 hours a day for 6 months. What we're doing is any remaining spaces, like you see here, we're just tightening those up. And we're just settling the bite. That's all we're doing. So none of this IPR is actually done. This is all just to settle the bite. And so you notice, looking from the side view here then, this is pretty much right from the side. We are a millimeter class 2. It sucks. It's annoying. I see this right now and like, I want to just like, ah, because we'd done it. We were there, right? We were pretty much there. We were in class 1. You saw it on the, I don't care about the photos. The ClinCheck shows you better, right? So the ClinCheck showed you right here. We were in class 1. We just needed to hold this. And sometimes what you need to do is, if you're worried because the space is really big, do a bit more class 2 correction even. Go even further back. Put them slightly into class 3 with the molar region, because as you close the space, your posterior teeth will drift forward a little bit. So anyways, that's what happened. I'm not here to try and fake it or lie or anything like that. So we have an open bite. I'm not perfect, guys. You'll have to forgive me. And so here's where we're slightly open as well, right? I never worry about posterior open bites. Who cares? We're going to settle it. I'm not worried about that, right? We bring all the teeth that are in heavy contact. We try to reduce the occlusion on those teeth. So essentially here, when you first look, when we're settling the posterior open bite, she's only hitting on a few palatal cusps on the 5, the 6, and the 7. The second premolar, first molar, second molar. So what do we need to do when we finish this case to finish settling it? We need there to be no contacts whatsoever on those spots. Because theoretically, you could go in there right now and take a burr and just chop off the palatal cusp. Not saying you should do it, but you literally just chop off the palatal cusp. All of a sudden, the bite, this posterior open bite right now, would just be like boom, psh, settled immediately. Or if they're an occlusion on the other side, it might not. But then those teeth will now no longer be hitting on one tooth and it will super erupt into full contact. But the other thing we do is we just literally go ahead and put a little bit of arch constriction. Well, I guess we didn't really do constriction. We did more buccal root torque and intrusion on these teeth here, just to settle this so that at the end, you should not see any contact whatsoever on the palatal cusp. No contact. Oh, you know what? Enhance, 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 enhance. Let's do it this way. Mother. No, I actually still had a little bit of contact on that palatal cusp. I think we can forgive ourselves. But this is how you settle a posterior open bite when you're hitting the palatal cusps. This is not a true posterior open bite on the 7, the 6, and the 5. The 4 is a true posterior open bite. There is no contact whatsoever. Oh, not super eruption. Occlusion. But like, am I worried about this tooth? No. Like, am I worried about posterior open bites ever? No. Worst case scenario, we jump in with a bunch of buttons and elastics and we pull these teeth down. That's always an option. But in reality, so this is the last ClinCheck you see then, because now she wears these trays 16 to 20 hours per day. It helps guide the teeth in the right spot. It helps settle the occlusion. We want the plastic out from between her teeth because we don't want it pushing her teeth back up and being too stiff. 2 weeks per tray, 15 trays. I want 2 weeks per tray now, whereas before she was changing out twice a week. She was changing every 3 days before for her previous movements because she's eating with her aligners in. Now she's changing out every 2 weeks with really soft, saggy trays that we want the plastic to get really thin and weak so it allows the bite to settle. Never Viveras at this point because the Viveras are too stiff and it won't let that posterior open bite settle. That's one of the biggest reasons why if you have a posterior open bite and you're like, Schalk, I can't get my posterior open bite to settle and it's been 6 months and they've been in Viveras, it's probably because your Viveras are too stiff and they might be wearing them too much. So instead, we go part-time. This is where she's at. 6 months later, boom, that's where she's at. Right, nice dialed in occlusion. It's much, much better. I look at things that I would still improve. Well, she's still slightly class 2. It could be better. But it's good for sure. The torque could be better as well. I feel like it's good, but it's not great. And you can see, look at her midline. Her midline is 1 millimeter deviated on her lower towards her left. Why is that? Well, because it makes sense. She's slightly class 2. We didn't do any IPR to try to correct this overjet or anything like that. We did all of this correction essentially with jaw repositioning by fixing the torque. Again, not as much as we should have, but and then through the distalization of these teeth. That's why the midline's still off, is because we didn't fully get her to class 1 on that side. Now, people ask all the time, well, am I worried about her only wearing elastics unilaterally? No, not really. Like, we use Carriere on single sides from time to time, so I'm not really that worried. I know there's some thoughts that it could result in TMD issues if you're using unilateral elastics, but I haven't had that experience, so I'm not too worried about it. Because the elastics help pull down, there's a vertical component to them. Look at how much better her cant is. Right? We did a bit of extrusion on this canine too, but her cant is much better from where it first started. So her smile arc, again, not a great smile. So she more like, this is what her smile actually looked like, although we were moving teeth slightly, so ignore the spaces. But that's what her smile looked like at the beginning. And then this is what her smile looks like at the end. So much better in terms of the aesthetics. Things that you need to be aware of with the Carriere, because I say Carrieres aren't magic and they're not always perfect, and that's why I don't use them on every case, is that Carrieres put a lot of force on the teeth, like crazy amounts of force. So if these patients don't have excellent hygiene, if they're smokers, if they have family history of diabetes and perio, if you have any worries about that whatsoever, be careful. Because with a Carriere, it is strong enough that it can cause clinical attachment loss. And you could result in a loss of a tooth if this patient gets perio that's out of control. And even with all that we did here, when you look at the gingiva, look at the height of this tooth. Again, I'm here to show you all of it and not BS you, right? The uprating of that tooth, and there is some intrusion on that premolar that's changed the height, but and she has some inflammation, some gingivitis on that tooth, but definitely I think there's some recession on that tooth compared to where we were. It's more of a pointed, um, it's a bit more sharp in terms of the scallop. So I think that we do have some recession on that too. So it's the reality is that orthodontics should be called compromise odontics. What compromises are we going to make? Are we going to compromise by not fixing her overjet? And that might be valid. We could have just straightened her front teeth. Are we going to compromise by potentially ending up with a higher risk of recession or perio? Are we going to extract teeth and give ourselves airway concerns and have a higher risk there with a compromise? Are we going to do jaw surgery and have a risk of paralysis and numbness? What's the patient's concerns? What are we trying to accomplish? In this patient's situation, we described the options of not correcting the class 2 and correcting it. And she said, no, I want to correct it. I want to fix everything. And I'm aware that there's risks of recession, just like there's already that slight recession and fraction that's starting to occur, but I'm okay with those risks. And so, yeah, she was okay with those risks. So it's something that, again, I say this all the time. Like I just got eye surgery done. And when I'm going through eye surgery, the surgeon says to me, eye to eye in the consult room before we go in. So, there's a 1 in 20,000 chance that you're going to get like permanent neuropathy in your eyes. You're going to have a burning pain. It'll feel terrible for the rest of your life. There's a chance that, through no fault of what we've done, that you'll have halos. So you won't be able to drive at night ever again. And you might have horrible dry eyes that feels like sandpaper. You're going to for sure have that for a little bit. It could be really bad though in the long term. So like literally, they're not shying away from this as a risk. Like there's a 1 in 20,000 chance that my pain is going to be so bad that it will ruin my life doing this laser eye surgery. I don't have to do it. I could go ahead and say, you know what, let's not do that. Or, there's another procedure where they try to put a glass contact on and it tries to reshape your eye, which will have other risks, but maybe not the same risk as what this one was. So there's all these different risks that are involved, and it doesn't mean that you did something wrong when there's recession on the tooth. We don't have the magical ability to do a procedure without ever having risks and complications. So it's more, have we properly educated and explained to our patients what the risks are? And if we have and they decide to move ahead, then they're knowledgeable about it and we'll address it if it occurs. And we want to ensure that we try to jump in and prevent it from ever getting to that point. Now, this is why I love dental monitoring, because this is my dental monitoring on the top again, where I can actually go in and see every set of photos that this patient has ever had on here. So this shows me every single week of scanning. And Invisalign has virtual care as well that shows it. But it will send me a flag as we start to get. Well, let's check to see, did it give us anything here about recession on the 2-4? I mean, actually, at the end of this series here, this was the end of series 3. It don't look bad. It's giving us some gingivitis notices. Yeah, it didn't actually tell us anything about recession on that tooth. So I guess maybe it is the same amount. You can see some of the inflammation before, but oh. But yeah, maybe it is the same vertical amount of recession. It just changed its shape slightly because dental monitoring is usually very good at picking up recession. If you want more than that, though, our group with Clearly Select is designed to help give you support at a higher level and to give you more confidence. So we help support you with ClinCheck designs. We have different faculty members who help with daily answering of questions. So when you're sitting chairside with a patient, you have that support. We'll help you with ClinCheck design with our 4 different ClinCheck experts. So 2 of them are orthodontists who design cases. Like, isn't that crazy? We have orthodontists in our community that will design your cases to give you videos to explain all the things that you might be missing, just like I did with this. You get access to all of the education. It's over $10,000 worth of education. Well, it's way more than that. It's over 20,000 actually, but it's everything that we have available is available to you. Again, both with business system strategies, TADs, like it's all there for you. And then we get awesome discounts because the size of our community is so significant that we're able to leverage significant discounts for doctors so that the average doctor in our community is saving over $30,000 on their lab. But the thing is, it doesn't even matter that you're saving $30,000 on your lab because the average doctor in our group is taking on 20 cases, it's 23 cases more than what they previously did at $5,000 per case. If that was your number, at 20 cases, that's $100,000 of extra billings that you're bringing in from doing these extra cases. Then add on the fact that the average doctor in our group is charging $1,000 more than they were than when they first started. That means that doctors are bringing in about an average of, said in the video, I think they're 130 or so $1,000 of extra billings per year for the average doctor in our community. This is my passion. This is what I love doing. And so if you're interested in being part of our Clearly Select community, then there's an application form. I'm sure someone in our team will link it in the chat here. We'll also send out an email to you guys. But I love doing this. I love it so much. I appreciate you all giving me your evening here and listening to my pitch.